All right. Why don't we go ahead and get started? First of all, just a really heartfelt welcome to our webinar on VBT Optimal Patient Parameters. We have an incredible group of surgeons with us today that are going to help us dissect what's out in the literature, also what their own personal experience has shown them about what works and what doesn't work, so we can really utilize this new technique in the most appropriate manner. Next slide. Today, I'm very fortunate to have my co-moderator, technical VBT whiz, Dr. Firoz Miyanji, and together we are going to be working with our incredible faculty to try to bring you as much information as we can on this topic. Next slide. And as you can see, our speakers do not need any introduction. We are going to start off with Dan Hoernschemeyer, followed by Noelle Larson. Dr. Miyanji will then talk about some technical tips and tricks, Dr. Lonner on complications, and Dr. Ahmet Alanay, who has recorded his presentation because could not be with us here, but has a lot of experience with the new evolving hybrid technique. Next slide. Really important. This is really for you guys. So please go ahead and submit questions into the chat. We will try to answer them, as many of them as we can. If there's time permitting, we'll try to get them during the Q&A sessions. Essentially, each of these talks is going to be approximately 8 minutes long with a 3-minute Q&A to follow, as you'll see on the next slide. Here's our agenda. Again, going to lead off with Dr. Hoernschemeyer on growth and optimal timing. Dr. Noelle Larson, all the work that she's done in shared medical decision-making, will educate us on what she's learned. Dr. Miyanji on his technical tips and tricks, and then Dr. Lonner on complication avoidance, outcomes, and incidence, and then Dr. Alanay with his recorded talk on the hybrid technique. Next slide. Now, it's really important, that everybody recognizes the Setting Scoliosis Straight Foundation. Our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. And we are a 501c organization that was established in 2018. Next slide. So with that, Dan, why don't you lead off and kick us off?
Thanks, Summer. So thanks, Summer. And choosing the right treatment really for scoliosis can be quite tricky, especially when trying to understand all the nuances of VBT. And so I'm going to go through with you guys just that about growth and, the optimal timing. And one of the first graphs that I can remember listing VBT as an option for scoliosis, really you can start to recognize there's a narrow treatment window for these patients when you lay out the important factors. So the curve has to be large enough to be worried about progression. The child has to have skeletally immature to allow for some growth modulation and enough curve flexibility so we're seeing a decent amount of surgical correction. In 2019, the folks at CHOP took the FDA indications and they applied it to their surgical practice and really found this to be about 21% of their surgical scoliosis population. But when we consider really the indication and how that plays into insurances, you can see here in red really what's highlighted as far as the indications and getting insurance approval. And so, as of today, we have Blue Cross Blue Shield, we have Cigna. I know in the state of Missouri, we have Medicaid. And then United Healthcare, as of April, really is the big player that has now had VBT approval. When I sit down and talk with families, I think it's important to understand the Sanders staging, but also where we're at with pre-peak height velocity and post-peak height velocity, and really trying to explain that and the importance of our VBT outcomes. And certainly understanding the curve size and our risk of progression. And so a lot of these patients are braced. This is the work of Dr. Kevin Neal and really looking at different curve sizes and just how that plays into the risk of curve progression based on their Sanders stage. And so when we look at different skeletal maturity assessments, we have triradiate cartilage, which helps us to understand both open and closed, but also the Risser staging, which has been around since 1958, and then the Sanders staging, which Jim Sanders described in 2008. And so here you can see, Risser is great in that we see that on all of our spine radiographs. However, if you look at this chart on our right, you can see that a Risser 1 could be a Sanders 2, or it could be a Sanders 7. And so really understanding that it doesn't give us the sensitivity really with pre-peak height velocity versus post-peak height velocity. And then when we consider Sanders staging and really looking for that growth modulation, Sanders stage 2 and Sanders stage 3, 3A, 3B is when we're going to see most of that growth modulation. And so this is some work from our SRS grant in 2025, 2026, where we looked at 70 patients with thoracic-only VBTs and really looking for that postoperative growth modulation. And really, when we looked at Sanders stage 2, Sanders stage 3A, 3B, we saw somewhere between 3 and 9 degrees of postoperative growth modulation. But when we looked at Sanders stage 4, we really saw no changes postoperatively. And then for the Sanders stage 5, we really, between first erect and 2 years, we saw a lot of curve progression for those Sanders stages. And we took this same data set. We really looked at height and growth modulation. We broke growth modulation out and those that did not modulate. And for those that modulated, we really found a mean growth in height of about 8.7 centimeters, as opposed to those who did not modulate, which was 6.2 centimeters. So we found that to be of statistical significance. And so really understanding that Sanders probably gives us much more detail than Risser when it comes to understanding that pre and post peak height velocity. Sanders stage 2 and 3A are really where we're going to see most of our curve improvement. And we're really looking for a mean change in height to see that growth modulation, ideally 8 centimeters or more. So here's your ideal candidate. And we want to take that high risk of progression now and change that into growth modulation. So we had a 57-degree curve for this patient. I had been following them. They had previously been 48 degrees. They had plenty of flexibility, and she was a Sanders stage 2. Then on first erect, we were able to get this corrected down surgically to 28 degrees. And then hitting that really peak growth velocity, we were able to get this modulated down quite a bit at that first year mark. You can see by year 2, we got it almost fully corrected. And by 3 and 4 years post-op, we were able to almost get this overcorrected to where I had to do a release. And she went on to do quite well, ended up with her curve in the teens. So growth modulation is so very important. And when we've broken this out, this got published in Spinal Deformity in 2025. And we looked at our modulators and we found a 91% success rate for that patient population, as opposed to a 44% success rate for those who did not modulate. So a 12.9 times likely to be more successful once you see modulation for your VBT patients. And so this is something you're going to see show up at ICIOS and at this upcoming meeting. This was 50 patients with thoracic only VBT, but really when we looked at the Sanders stage 2, we saw the highest growth modulation for these patients, but you need to prepare your patients for a second surgery if a release is needed. For Sanders stage 3, we saw high growth modulation, and a high success rate of about 70%. With a Sanders 3B, we saw a maintained 70% success rate with a slightly smaller cob. And when we got beyond, Sanders stage 4, beyond growth modulation and success really was unpredictable, is what we found. So in the end, the ideal VBT candidate, we really, really need to have growth modulation. And so we want to look for that patient who's a Sanders stage 2, 3A, or 3B, open triradiate cartilage, curve magnitude somewhere between 45 and 65 degrees. We're looking for this high risk of progression patient. And then also with curve flexibility, because we really want to obtain a decent amount of surgical correction. So thank you.
Great, Dan. That was absolutely excellent as usual. And kudos for all the work that you and your center has been doing on modulation. So I appreciate everything you've been teaching us. Baron's got a question in that, have you seen different patterns as it pertains to growth modulation? In particular, with respect to sort of, the different kind of curve types. I wonder if Baron means, thoracic curves versus lumbar curves, or do you kind of assess people at Sanders 2s and Sanders 3s and still use that same criteria regardless of, like, are you doing a thoracic VBT or lumbar VBT?
So much of the data that I presented is mostly thoracic VBTs. I think when we think about that, we call it the danger zone. We really have to be careful. We've talked about that at meetings. I think between T11, T12, L1, things can certainly modulate quite quickly through that area. So we, sometimes we'll provide some slack. But I think, we're going to probably tease out more data in the future as it pertains to the thoracolumbar curves.
The question I had for you, Dan, so over the years, are you doing maybe more immature patients rather than mature patients, and that if they overcorrect and you're following them, you're going in and doing the release? Or has your practice, not changed as much in that, you've always done the 3As in some of the 2s with larger curves? Can you kind of maybe, let us kind of tell us what you're thinking?
Yeah, good question, Firoz. So I think when I presented and kind of wrote on some of our midterm data, I think I went back and looked, and only about 35% of the kids were what I would describe as ideal candidates today. So I think we've definitely narrowed our indications over time. And I think that, whether we're really, bracing and waiting for some of those skeletally immature patients, I would say a Sanders 3A, 50-degree curve, 55-degree curve, and then watching that modulate is probably the ideal situation. So, but I think, when you're dealing with a Sanders 4, as I talked about, if you're trying to maintain flexibility, let's say in the thoracolumbar spine, to me that makes a lot of sense, but there's still some unpredictability beyond Sanders stage 4.
Good for you. Thanks, Dan. That was outstanding. Ro, I do see your question in the Q&A, my friend, and Noelle's typing an answer for you. Thanks for signing up. Rolando, down in Sacramento, he had a question about open triradiates in less than 10. Obviously, we do worry about overcorrection, but Dan showed us nicely how you can release that. Just in the interest of time, we're going to keep moving on. Our next faculty is Noelle Larson. Clearly does not need much of an introduction, and absolutely outstanding mind, has taught us a lot in the non-fusion space and really helped pioneer this area, and in particular when that decision of whether the patient should be tethered or fused. So Noelle, please take it away.
Oh, well, thank you so much, Firoz, and truly my pleasure to be here tonight with this illustrious group, and hopefully we can all learn from each other to make this procedure better and more predictable. And I think one challenge we'll hear is that the data set regarding Tether is still coming, and we're all working to see different corners of the elephant and different pieces of the puzzle. And there's things such as growth and patient selection and patient and child preferences, and all these things need to kind of go into. So early on in this journey, I think through Studying Scoliosis Straight Foundation, we had a real dedication to families and how are we going to provide the best information right at hand. This actually started with a partnership with the FDA and Dr. Lonner and many other people on this call here tonight. And our first step really was to develop a patient preference survey to understand what do patients and families care about when they're selecting a surgical treatment for their child. And then our second aim was to develop and test a shared decision-making tool. So starting out, we just surveyed a bunch of patients from 7 different hospitals and their parents who either were at least 3 years post-op from Fusion or Tether, or who are in the process of trying to decide what would be best for their child. And these were kind of the criteria that we gleaned from the survey of what would families care about and what do they think about when picking a treatment for their child. We had a total of 320 participants and a variety of pre-op states, and they completed this quite arduous 20 to 30-minute questionnaire. And our results really showed that the important drivers were really spinal motion and appearance. And families thought less about recovery time, chance of reoperation, and confidence in the device. Patients that had selected Fusion really cared about appearance and device failure rates. Vertebral body tethering patients really had thought about motion, recovery time, and had less concern about their maximal curve correction. So our second aim was to develop a point of care tool that the physician can use in conjunction with the child and the parents to try to explain all the complexities of what you just heard so eloquently from Dr. Hoernschemeyer and other speakers, like what procedure is going to be best for your child and your family. So I'm proud to say we've launched this tool and it's publicly available on the Studying Scoliosis Straight website. There's been over 1,000 hits since we launched it just 9 months ago. So that makes me think that we're using it. When you click the first box, it's actually going to give you a log on, but you actually don't have to log in. You can just X out of that, but please do log in because it helps us understand, again, how to make the tool better. And this, again, is meant to be used in the clinic at hand, doing it real time with the patient and the family. There's 2 nice little videos that you can watch either before you come into the room or during, and the families can learn a little bit more about Fusion and Tether. We have pictures of what a Fusion looks like, pictures of what the incisions look like for a Tether. And then it dives into this comparative experience. And this is really your opportunity to ask the child, what do you want to hear about? So I say, do you want to hear about straightening, flexibility, recovery time, chance of needing more surgery? And we reassure families both surgeries can help with pain, they can help with curve correction, they can prevent future health problems from your scoliosis. And then the child will kind of pick, what do they want to hear about, which of these 4 parameters. And then there's a little cartoon that goes with it. So if we want to hear about straightening, on average, we're getting more correction, more straightening with a Fusion compared to a Tether, more spinal mobility with a Tether compared to a Fusion, recovery time, a little shorter with a Tether compared to the Fusion. And then chance of a second surgery, much, much higher with a Tether compared to a Fusion. And then families can really decide what they care about. And I'll say I do tailor this individually for the individual family. So if the curve is bigger, if the child is not very active, I'll kind of talk them through this and kind of make this a tool for them to explore options for their child. I mean, I often will show a photo of, like here's a picture of overcorrection. If someone has open triradiate cartilage, 40% chance they're going to need a tethered a release of the cord in my practice, which involves usually an overnight stay, 30, 40 minutes of surgery, and a relatively small opening of their old incisions. We also have a big list of published data that support what we have in the tool, and we plan on reworking the tool over time as more data comes out. So utilization of the tool, we've videotaped usage of the tool in 40 patient-surgeon encounters, and we found that people spend on average about 5 minutes going through the tool. But interestingly, the child talked much, much more, 3 times more minutes or seconds the child talked rather than without the tool. So it kind of empowers the family and the child. In addition, most people recommended the tool and were satisfied with the clinical discussion. So I think really what are next steps? Like I would love to kind of risk stratify this and include a calculator. Many of the other shared decision tools out there have a calculator, so you can look at your individual risk as opposed to the published data. So could we stratify low, medium, high and kind of talk people out of the tether if we know they're going to be a terrible candidate with usage of the tool? Also, can we correct for surgeon experience? So in our hands with our Mayo FDA IDE, we found that intraoperative correction is really critical in order to have a good outcome. And if you leave the cord loose and sloppy, it's going to break and you'll have decreased correction over time. So could we account for like what was the amount of tensioning that you achieved at your last 3 to 5 surgeries? And is that going to help you do risk stratification for your patient and your families? So again, we liked tension. I'd rather overcorrect than undercorrect because as you see, catching overcorrection early is not so big of a problem, and undercorrection is really quite a significant problem. So I even have a little video of trying to make sure retention. There might be other factors too. So kind of in our Mayo multivariate analysis, the main factors that were associated with success at 2-year follow-up, an average 3-year follow-up, was first direct, and as well as mean preoperative COB, as well as patient height. So those taller families that have higher growth potential may have a better chance at success. Right now, these are kind of my current indications, and these are my moving targets, but I'm really hopeful to turn all this into a science with surgeon-specific and patient-specific data so that we can really drive better outcomes for our patients and our families. In my practice, I do younger patients, but I also do older patients, and I have had very nice results in some of these older patients. These are 5-year outcomes on fairly mature patients. So now she's 18. She only grew 1 centimeter since her time of index surgery, and you can see pretty nice balanced result. Another patient 5 years out from VBT, surgery is done at Risser 3. She only grew 1.5 centimeter. She's balanced. She jumps on her trampoline. She does some light gymnastics and very happy with her results. There's lots of efforts underway to do finite element analyses and be able to do the surgery in vitro before we actually do it in vivo, and nice little models where you can, again, model the amount of correction that you're going to see over time and use this to guide your surgical choices. So I think, in short, let's keep all working together. If we have patients, families, researchers, surgeons, and physicians all working together, we can't go wrong. And I thank each of you here tonight for attending. Thanks so much.
Noelle, spectacular work in this space. And, there's over 450 articles actually that have been published in the last 5 years. You've actually contributed a large percentage of those. So thank you for improving our understanding. I've got a question for you, Noelle. So now that you've been utilizing this tool, how do you feel your practice has changed, i.e. prior to utilizing the tool and currently utilizing the tool? How has your practice changed?
Well, I always have a challenge when you go in the room and the family is really sold on one treatment option. Many patients have read on the internet and they're convinced they want the tether, or other families are convinced they want the fusion. And I go into that room and I give the exact same talk every time. I am not biased, and I feel that every family deserves the same information, the same presentation, maybe tailored to their specifics. Is it lumbar? Is it thoracic? Is it 55 degrees? Is it 49 degrees? But I try to give the same talk every time and try and provide age appropriate and family appropriate information based on the literature. And this tool helps me do that.
Yeah, I mean, what I hope and I really encourage all Tether users to utilize this tool with their patients so we can get consistent information across to our patients, whether they're being seen at Mayo, they're seen on the East Coast or the West Coast. Firoz, I think we could probably take one more question if it's coming through the chat, if you see anything.
There is a question about the youngest age a child can have a VBT. Somebody's got a daughter 4 years old with a 40-degree curve. I would probably suggest that would be far too young for VBT, implant size, growth modulation, et cetera. So in my practice is generally 10 and above. But Noelle, I don't know if you can give us a quick answer in terms of age in particular, your cutoff.
Yeah, I mean, it's a little bit, there's so much growth potential, and even an 8 or 9-year-old that you're almost guaranteed to be looking at 2 surgeries. So in the very young age group, like in my hands, youngest we've done is a 9. Like very high chance of needing 2 surgeries, and it's kind of an alternative to a growing rod, which also requires, 2 surgeries always. I think 40 degrees sounds like a wonderfully braceable curve, and most 4-year-olds are willing to brace, maybe not all, but certainly I think you have time, and 4 is probably too young.
Yeah, and our advice would be very similar as well. Brace for now, and then the youngest we've operated on is about 8 years of age. Excellent job, Noelle. Why don't we take it to Dr. Lonner, who has really been pushing the limits right from the start with VBT. We want to thank him for that. He's certainly taught me a lot over the years and helped me expand my indications appropriately. So, Baron, go ahead and teach us about complications, incidence, outcomes, and avoidance.
Thanks. Hopefully, I haven't had too many myself, but I think I've learned a lot along the way. So, as Noelle discussed about the importance of how we introduce new technology, certainly for any innovative procedure that we introduce, in this case, VBT, should offer advantages over the standard of care, fusion, namely preservation of spinal flexibility. Perhaps it's less invasive with quicker recovery and less postoperative pain, and there's less bleeding during the surgery. But there may be disadvantages, such as the learning curve for the surgeon. Noelle brought this up. Who to operate on, when, and how to do that. And certainly there is the potential for introducing new complications that don't exist with the standard of care, particularly early on in the adoption. And we looked at the learning curve associated with thoracoscopic fusion 21 years ago. The X-ray on the right looks very similar to our VBT X-rays, except we've got a metal rod and a spinal fusion. And what we found in our thoracoscopic fusions was there was a 28 case learning curve before we could really substantially decrease operative time and improve spinal corrections. Probably a little less for VBT, but it's significant. So what are the complications associated with this procedure? I think we can divide these into approach-related procedures. We are going through an anterior thoracoscopic approach, mini open, pure thoracoscopic, single lung ventilation is utilized. And then there are procedure-related complications, largely overcorrection with growth and tether breakage with potential loss of correction. Now, we expect tether breakage, and perhaps these problems are only a complication if inadequate correction in the end is achieved and or reoperation is required, especially fusion. So, as Noelle said, we can release the tether. Dan said this as well. We can release it, remove it. We've gotten them to growth modulate. We've got a nice correction. That's not quite as bad a complication as going on to fusion. So we looked at the HARM study group database under the Setting Scoliosis Straight Foundation to look at patterns in the procedures that we've performed over the past 3 decades. The database at that time of patients with minimum 2-year follow-up through from 1996 to 22 were 4,500 patients, average age 14. Most were girls. And if you look at, here we're looking at procedures, posterior fusion, VBT, anterior fusion. And we've got quartiles. VBT only had 2 quartiles. We started this much later. But if you look at blood loss per instrumented level, it's so much lower for VBT compared to the fusion cohorts. So that's a remarkable finding. And then when we look at major complications, look at how high they were in the first quartile, 1996 to 2000 for posterior fusion, almost 30%, and a little higher than that for VBT. And in both cases, they've dropped down dramatically. And I think we're probably going to find a similar pattern for VBT continuing to decrease as we learn and gain experience. And then reoperations per procedure, sky high for VBT, and then that cuts by more than half. Now, a lot of those were tether releases, and some of them were fusions. So I think we've got to look at this data and learn from it. Obviously, with this operation, growth modulation is what is occurring, and it can be quite powerful for even a larger curve, 10-year-old girl, Sanders 2, and she corrects and even slightly overcorrects. But this is the power of the procedure with an excellent clinical outcome as she approached skeletal maturity. We looked at our operative morbidity, so the approach-related complications largely with early follow-up, 3-month follow-up in 184 of my early cases. we had 3 cases of chylothorax, 2 hemothorax, and these were associated with patients in whom we did internal thoracoplasty. So rib resection was associated with those 2 cases. And we had 1 lumbar screw that had to be revised for radiculopathy. And the list of approach-related complications is here, and I won't go through it in detail. Patients often ask, what, doctor, you're deflating my daughter's lung with this technique. What's the impact of that? And we looked at pulmonary function following various procedures, including thoracoscopic technique for fusion patients years ago, and found no lasting effect on pulmonary function, although there was a slight decline for as long as 1 year following surgery. Probably will be similar for these patients, maybe less. And then there are the procedure-related complications. Much of this comes from our literature review that we published in 24. So tether breakage rates on average for a mean of 2.5-year follow-up was 21%. In my own series with Dhruv Shankar writing this up, 69 patients, we had a 1 in 4 patient basically had at least 1 tether breakage at 2-year follow-up. And when we stratified it by major curve location, the thoracolumbar curves had 1/3 had breakage versus only 8% for thoracic major. At that time point, there were no differences in radiographic correction between breakage and non-breakage patients. Then when we looked more recently at our minimum 5-year follow-up, we presented this at IMAST recently, 80% had at least 1 tether breakage, and many patients had multiple breakages. Again, the mean reoperation rate, so this is from the literature, was 8.3% in this literature review. I think it's underreported, especially if you look at the harm study group data. And 2% of that 8% were from tether breakage, but majority of those patients was from overcorrection. There were some CSF leaks, screw displacement, radiculopathy, and here's one where the screw plowed and pulled back a little. This patient elected not to have that revised and stayed in place for years after that. Dan presented very elegantly on the the growth modulation with Sanders stage. Just this smaller study by Dr. Alanay showed mechanical complications were much higher with Sanders 2. This could be screw loosening and tether breakage, and they dropped dramatically from Sanders 3 and up. And overcorrection, again, very high, 80% for the Sanders 2. So we expect that. And so that's part of the indication and the timing and when you want to address the patients. Here's a boy that I operated on, again, with a large curve. He had been offered a magnetically controlled growth rod, and the family really wanted to avoid that. And we took this on. Didn't look very good at first direct. At 2 years, he's already starting to overcorrect. And we were planning on, we were kind of anticipating that we would have to do a tether release. But then he fortuitously broke his tether at a number of locations. He's now 6 years post-op and approaching skeletal maturity. I think he'll be okay. And the family wanted to avoid this, and they did. Here's a girl where she's overcorrecting, and we were planning on releasing the tether, but she did a lot of flip turns as a swimmer, butterfly swimmer, and she broke the tether for us. And she got record times after her surgery in butterfly. And this boy, I just recently operated on him. He growth modulated nicely and started overcorrecting. We just recently removed his tether. It was a relatively benign surgery, 2 hours, 50 cc's of blood loss. We took the whole tether out and 3 days in the hospital, and we'll see how that does. Hopefully he won't continue to correct in the other direction. Here's another patient. We had offered this family a fusion of the proximal thoracic curve initially and tether below. But they wanted us to try to just do the tether, and we needed close follow-up because we were concerned about this. COVID hit, and then there was a loss of continuity of care, and then she overcorrected proximally, and the proximal curve increased. So we revised this with fusion of the thoracic spine only, and extension of the tether distally, and she's now several years out, has done quite well. Just a few more cases. Here's a tether breakage. Probably should have done both curves, either with a hybrid or a bilateral tether. She broke her tether. Today we would have done a dual row tether here in the lumbar. Broke her tether, the thoracic curve increased, and we revised her with a fusion and added another row of screws in the lumbar spine. She's soon to complete her nursing school and will be going on to become a nurse. Bilateral tether here in this 15-year-old boy who failed bracing. Then he breaks at every level at 5.5 years post-op, but has an excellent clinical outcome. And I just saw him. He's now at 8 years post-op and doing very well, despite all the tether breakages. So that's not really a complication in my view. Here's a young man who just got a championship win in the backstroke in a Division I competition. And he broke his tether along the way over many years of flip turns and these kind of arching his back. And I think that's a better looking back than following tether than I think you would see with a fusion. So strategies to avoid failure. This, I think, certainly we would apply some of these techniques for larger curves and patients who are more on the skeletally mature side, so the higher Sanders stages. And these include double row tethers, apical fusion, and hybrids. And I won't go into great detail, but essentially here we have a double row at the apex to take on this 60-degree curve that was a bit stiff. And, this actually was, I think, very helpful to overcome and get good growth modulation. And then we've taken on, this is a 17-year-old boy, we've taken on larger curves with less growth remaining. And here I did a 2-level apical fusion, one with an XLIF cage, and this one just soft bone grafting. And he's about 6 or 9 months out, doing well so far. The tethers, let Dr. Alanay speak to this, but we have taken on more mature patients and large thoracic curves and doing our best to preserve the lumbar spine with a dual row tether. So I think in summary, we have approach-related and procedure-related complications. There is a learning curve. I think we will all learn from one another. The timing of surgery is important, both in terms of curve size and growth remaining. And some of the strategies listed below can maybe help us improve some of our outcomes. Thank you.
Great. Thanks, Baron. Outstanding job. I'm just thinking in the interest of time, we might do your question and answer after I do my talk, and we can kind of do it together unless anybody's got a pressing question for Baron while I pull up the other talk here. Can you all see my screen okay? Yeah.
Yes.
Okay. So I'm going to go over some technical tips and tricks in the space of VBT. And again, this is simply going to be much more of a technical procedure. I do have some disclosures, nothing relevant to this particular talk. First and foremost, in terms of positioning and exposure, a few pearls that I've learned over the years. I'll talk about how to facilitate your camera placement, maybe get this passive correction of your deformity so you don't stress the implants, and how you can try and optimize your portal placement strategies. Those of you that have done scopes around other joints understand that portal placement really is key. This is a space that surgeons may be getting into, especially a thoracoscopic procedure. You're now in a two-dimensional space, so it's nice to kind of optimize this. Now, we all know for your tethers, the patients are going to be allowed the cubitus position, but when you're doing a scope, I think it's really important where you put that shoulder. You don't want to abduct it, you adduct it, but you got to flex it a little bit beyond 90. And it helps me because when I put the camera in that proximal portal, looking distally, that shoulder can get in the way. Now, it's also important to warn the patients that they may have a little bit of shoulder discomfort because of the pressure of your camera when you're looking primarily at your distal levels. The other thing in terms of the passive correction, I usually put bolsters, one under the crest, and sometimes I put it under the upper arm as well. That levitates the torso off the table, and so you get this nice passive correction of your deformity in the space that you've created. And then what I'll do is before I prep and drape, I bring in the fluoroscopy. As I bring in the fluoro, I get a lateral x-ray and I use a little K-wire and I'm trying to mark out the midpoints of the vertebral bodies. And then I swing it over into an AP view. And again, I use this K-wire, and where these lines intersect tell me exactly when my screw shots are supposed to be. And why that's important is that it allows me to know exactly what I'm going to do for my instrumentation portals. So I can see where my screws need to be and I can plan my portals accordingly. And so when I'm prepping and draping, I haven't really draped this area out, especially proximally. So it's really important for me that I get the fluoro in before I do any of the prepping and draping. Next is your room setup. So, it's dealer's choice, but I do my own approaches. So when I do that, I will stand in front of the patient and do my exposure. And then when I instrument, because I'm a right-handed surgeon, I then go on the posterior aspect and I instrument from distal to proximal. And again, it's just the way I like to do it because I'm a right-handed surgeon and I do my own exposures. If you have an axis surgeon, you may want to stand on the same side. That's fine as well. And again, you can see where the instrumentation portals are going to be. They'll be a little bit more posterior, and you have at least two. Sometimes surgeons use 3 working portals, but for me, 2 working portals are very adequate. One for the scope, and then the other one for your harmonic or any other coagulation item that you're going to be using. First thing is first, you're going to put in that proximal anterolateral portal. You'll get a view like the one you see in the right-hand corner on the bottom, where you see your disc spaces and the vessels around the vertebral bodies. I usually use this hook harmonic because I can open up the pleura longitudinally, and then I basically will anneal the segmental vessels. And then I'm just basically pushing the pleura posterior to the rib head and anterior to the ALL. So this is pretty much what you need to see, or your exposure. It's not a big exposure. Again, we're not doing an instrumented fusion. All we're trying to do is an instrumentation and place the tether. So rib head to ALL is what I like to see. Now, in terms of instrumentation pearls, I'll tell you what I do to try and avoid screw plow, and then how you determine a safe starting point for your screw entry and why that's important. So in terms of anterior spine fixation, these screws don't fail in pull-out, right? They fail through plow. And so what measures can you do to prevent plow of these particular screws? And we've got some good data out there. A lot of work was done in San Diego. My mentor, Peter Newton, has done a tremendous amount of work in thoracoscopic fusions as well as in tether space. And they noted that if you increase the screw diameter, you significantly increase your fixation strength. Next, if you add a staple, because it increases the surface area of the tulip of your screw, you can actually increase your loads. In these cadaveric models, the loads were increased by 280%. So the staple does add significant weight when you're looking at avoidance of plow. And then finally, Brian Snyder's group down in Boston showed that the strongest and most rigid construct for anterior spinal instrumentation is a bicortical screw that's inserted through a staple. So for me, I always use a staple. I always go bicortical, and I do use the largest diameter screws, despite some of the feedback I get from my surgeon colleagues around the world. Now, in terms of where you should put this staple and anchor to begin your screw placement, I'll kind of show you how I do this. When you're looking through the scope, it's the image on your left there. You've got your pleura open and you see your vertebral bodies and your disc spaces. But on the fluoro, you'll see the anterior and posterior aspect of your vertebral body, and you got to understand where the canal is. So I use a feeler. I basically insulate it with a Foley catheter. So when I put it in and I look under the fluoro, I can actually see the tip with respect to the posterior vertebral body. If you do use the all-through-one, whatever system you're using, it may preclude you from seeing that posterior wall adequately. And then basically I just cauterize it and I see these little marks, so I know where I need to be front to back in terms of either midpoint or a little posterior in the body, wherever you want to be, but it does tell you in relation to the canal. Generally, on a single lateral x-ray, I can mark at least a number of levels, at least 3, if not 4 levels. And this prevents me from going from a lateral to an AP to a lateral to an AP for each particular vertebral body that we're going to be instrumenting. And then from there, you swing your fluoro into an AP view, and then you introduce the all end staple complex onto the dot. Want to stay parallel to your end plate, and you basically are going to mallet it down. And now you've essentially committed in terms of your front back where your screw is going to be positioned. Then you remove your you introduce your tap. Again, I like to go bicortical and stay parallel to the end plate, and then you can read off the length of your screw right off the tap, either proximally or within the wound itself, through the window that you can see thoracoscopically, and then you remove the tap and then insert your screw. It is important to tap. I know historically in the anterior fusion spaces, some people don't tap, but it's important to tap because that allows you to get the length of the screw measured appropriately. And why I think this trick is important, because it ensures a smooth transition of your screw, so one is not posterior or anterior to the other, and your tether has a nice smooth contour when it's going from proximal to distal. So again, you want to target it, and then you want to introduce your all in staple complex, and then you introduce your tap and your screw of your appropriate length. So those are pretty much the 3 steps for instrumentation. Now we go on to tether placement and tensioning. So how do you avoid the segmental overcorrection? And Dan spoke about this very eloquently, saying that, usually T10, T11, T11, T12, or at thoracolumbar junction, we sometimes see overcorrection and we don't kind of see it smooth. This is the 10-year-old Sanders too, and you may think they're going to overcorrect because of their Sanders score, as Dan nicely pointed out. And is this overcorrection uniform? But it wasn't. Over 3.5 years, they had more of a segmental overcorrection, as did this patient, another 10-year-old female, Sanders too. She went on to overcorrect a little earlier at 1 year, so I just went in and snipped the tether distally. But how do we try and avoid this? Now, when you look at the tether, there are particular zones of the tether. There's an introduction working zone and then the functional zone. So that zone between the blue lines is what you want to implant in the patient. You need an anti-torque, you need a tensioner, and you can use this device called a snake, so you get segmental tensioning between one level versus the other. So when you place your tether, I like to go from proximal to distal, and I get maximal tension at the apex. And if you can see on these images, at T8, I marked the tether and it was within the tulip. And after the tensioning is done between 8 and 7, that mark is almost down to the T9 tulip. So you can get some powerful correction and tensioning with the devices. So again, for me, the greatest tensioning is at the apex. And proximally, what I'll do is I'll simply lay the tether down. I put the anti-torque and I'm just putting these set screws down. And you can see I'm not doing any tensioning. It's once I get to the apex, I introduce that snake. And if you look closely, you'll see how that anti-torque is being drifted closer to the next tulip as the tension is being removed, and you're going to get some correction. Now, how do I judge this intraoperatively as well? Both visually through the scope, but I also look on the x-ray. And what I'm trying to do is I'm trying to make these particular end plates nice and parallel, because what we're trying to do is reverse the Hughes-Volkmann principle or the Hughes-Volkmann force, and you're trying to eliminate the added stress on the concave end plates, i.e. those growth plates. You want to compress the convex end plates, and if you do that by making the disc parallel, you'll get that growth. So as you heard from the earlier speakers, it is important to get correction. I've never just simply placed the tether and not put any tension on the tether. I think it's very important to get the correction so that you can get modulation over time. So the goal, generally, a lot of surgeons always kind of ask me, what do you get on the table? I really use this number very loosely. For me, it's really the parallel end plates per level that helps guide me in terms of the correction that I'm getting. Now, Dan also talked about this very nicely, and this is sort of one of the pearls at the distal segment. Many times by positioning the patient alone, especially in the lumbar spine, you can actually get overcorrection. That final disc space might already be closed on the one side before you tension or place the tether down. So you want to leave some slack, and you can just leave some slack by doing something like this. You can basically put the anti-torque on the tulip, turn it 90 degrees, turn it back, and you'll see a little loop. And hopefully that will avoid the segmental overcorrection that we've learned over the years, especially at that thoracolumbar junction. And the final pearl, we tend to think that VBT is for everyone, and I just want to really highlight that it's not for everyone. This is a 14-year-old female. She's 2 years following her menarche. She's already taller than her mother. A selective thoracic fusion was recommended down at T12. Went to another center, had this construct for a VBT, unfortunately failed over time. Now will require a fusion, but the fusion level is very different, right? It's down into the lumbar spine as opposed to a selective thoracic at T12. So it's really important to recognize that VBT is not for everyone, and work like Noelle's done and all of the faculty on this webinar. I think we all agree that it is. It is our responsibility to help our patients with their decision-making process, and many times it's okay to say no. You heard from Dan that their window is also narrowing in terms of indications for a successful VBT over time. And finally, just to talk about other items that you can do to help optimize your outcomes. The Setting Scoliosis Straight Foundation has a very eloquent QI registry. And this is the Surgeon Performance Program, and we've done it for spinal deformity over many, many years. And it's really designed so that you can look at your performance and try and improve your patient outcomes. If you enter at least like 5 cases per year, you get a dashboard that's risk adjusted. It'll look something like this. The good news is that in the Tether space, we've also been able to offer this. You can get a dashboard showing your constructs and your kind of procedures with respect to the others. And you'll get a whole bunch of metrics from OR time to blood loss to your COB correction, kyphosis, and lordosis over time. So I think this is a very healthy way of entering the space for VBT because you can actually measure and follow your patients. And I think it's crucial that in the VBT space, patients are followed over time. So becoming a participant is very easy. Here's a QR code. We'll see this at the end of the webinar as well. And again, you can get automated risk-adjusted dashboard reports twice a year. The ABOS maintenance of certificates for the U.S. surgeons, you can certainly use that to get that maintenance of certification. You can get 10 credits annually, and obviously at your centers, you can have a lot of QI project opportunities. We've also partnered with POSNA, and I'll have Noelle say a few words at the end of the webinar around this on the SQUID program. So for those surgeons that are also pediatric orthopedic surgeons out there and you're part of POSNA, there's this opportunity to enter into this QI registry. And with that, I want to thank you, and I'll stop sharing my screen and we'll move on to any quick questions if anybody has.
Yeah, absolutely. Firoz, a spectacular job on that. Obviously, so much to talk about. I think we will probably end up overrunning a little bit, but the information is so valuable. So thank you for going through all of that. We've only got one more talk to go, and I think looking at the timing, we're actually okay to get through a couple of questions. I think Baron or someone else put in the chat, what about screw placement on the vertebral body, Firoz, to try to optimize rotational and sagittal plane?
Yeah, I think rotationally, I don't think we have too much real estate. I mean, there has been thought like, at the apex, if you kind of cheat your screws a little bit more anteriorly or kind of rotate them out. But again, it's a rope. So that rotational component, I think if you growth modulate, and Dan and Mel has shown this really nicely, that if you growth modulate, you'll get that apical rotation. However, sagittal plane, I do believe. I think in the thoracolumbar curves, you got to cheat those screws posteriorly because we know anterior procedures are kyphogenic in nature. And in the thoracic curves, I generally go midpoint of the body. Sometimes, if I see hyperkyphosis right from the get-go, I might go a little bit more posterior because I do get a longer length screw, the most posterior I go. But qualifying that with what you've been always teaching, Almer, the shapes of the vertebral body, right? They're a little concave at the back. So be really cautious of how far posterior you're going, especially in the thoracolumbar and lumbar spine.
Yeah, no, excellent job, Firoz. I'm sure there'd be a lot more to talk about here, but just in the interest of time, I do want to get one question quickly in for Baron as well. Baron, I think it was put out into the chat, complication rates. What are your thoughts now that we've got this learning curve? How do you think they're going to evolve over the next 3, 4, 5 years?
Well, thank you, Amr. I think it was pretty dramatic for us to look at the 3-decade experience and then look at the procedures and how the complication rates dropped for fusion and now for VBT. Both reoperation rates have dropped dramatically and major complications. So I think refining the indications, I've been known to push the envelope a little and push the limits because I treat both pediatric and adult patients in my practice, and I also see the impact of a long fusion into the lumbar spine. One of the attendees asked that question, thoracic tether versus lumbar. And for sure, fusions into the lumbar spine, especially to L4, but even L3, can result in adjacent segment problems. And I see those patients in my practice all the time, including my own and other surgeons. So it's a real problem. And so for that reason, I've pushed the envelope and I've approached patients who are not likely to growth modulate as much or at all, potentially. And so that's where I think the addition of dual row tethers, but they still break, and now apical fusions, which is a work that Per Trobisch has introduced to us. I think those are going to allow us with strengthened cords, better quality tethers, maybe the ability to push the envelope a little further. But I do think we're going to see continuing improvement in the risk profile.
Excellent job. We will move on to Dr. Alanay, who's unable to join us live, but has recorded a video of this talk, which we will play now on lumbar and hybrid tether.
Hello, everyone. Thank you, Amir and Firoz, for inviting me for this webinar. So I will address two questions in 8 minutes. When do I tether the lumbar spine on its own? And when do I add a thoracic fusion and make it a hybrid? These are my disclosures. Several studies have shown that motion does remain after thoracic tethering, but the thoracic spine contributes little to trunk mobility. The lumbar spine, on the other hand, is different. Lumbar VBT preserves motion patients actually use, and sparing these lumbar segments still shows a benefit at 10 years. So the lumbar curve is where a tether earns its mechanical risk. That is the lens for the rest of the talk. For a lumbar or thoracolumbar tether, my criteria are these. Patients 10 to 16, rapid growing, Richter 0 to 3, centers 3. But I also do selected steady growers over centers 4. If the alternative is taking a fusion down to L4, I will still tether even knowing I get little growth modulation in this patient group. Regarding curve, 40 to 60 degrees, at least 50% flexible or bending below 30, mainly lanky 5 curves. Where I stop, Sanders 1 or 2 with 3 radial cartilage still open. I try to buy time with bracing, and as you know, the lumbar spine is the easier one to brace. A rigid curve that will not bend below 30, and anything beyond 60 to 70, and a lanky 5 whose thoracic curve is over 45 degrees, those patients becomes a hybrid for me. Here is where the field stands. Sandanis group, the largest lumbar series, 106 patients, 4-year follow-up, 50 degrees down to 20, 3/4 under 30, but a 19% reoperation rate. Boyer's thoracolumbar cohort, success only 57% and more than half with a suspected broken tether. My own 21 thoracolumbar tether sits just in between. 80% under 35 degrees, breakage 40%, revision and conversion to fusion 5% each. Two things the literature agrees on. Lumbar tethers break far more than thoracic ones, and most of those ruptures are inconsequential. My read is that the lumbar tether corrects reliably and holds. The cord fails when it is asked to do too much. That is what takes me to hybrid. A typical one, 14-year-old lanky 5, Sanders 4, a steady grower, not a rapid one, lumbar curve 42 degrees, thoracic 27 and non-structural. Lumbar tether T10 to L4. On the first erect film, the lumbar curve is 9 degrees and at 6 months 4 slightly overcorrected, which in the lumbar spine I accept because the cord will probably break eventually and I will lose a few degrees. And that is exactly what happens to this patient's tether breakage, 18 1 year, 19 at 3, 23 at 5. So she finishes Sanders 8, 161 centimeters with a 23 degree lumbar curve, a mobile lumbar spine, no revision and no fusion. The thoracic curve, on the other hand, corrected on its own from 27 to 18. This is the heart of the talk. I ask 3 questions to choose a hybrid solution. Does the thoracic side say fuse? Well, Sanders 4 or beyond with a curve over 50, no meaningful modulation left, or a curve over 60, and that includes the Sanders 2 or 3 child who is perfectly timed for a thoracic tether, but whose curve is simply too big or will not come below 30 on bending. Severe hypokyphosis is another thing. Second, does the lumbar side say tether? A lanky 1C with a lumbar curve over 45, where a selective thoracic fusion alone risks decompensation or progression, and where, if I fuse instead, my LIV would land at L4 or below. Third, does the patient agree? This is a shared decision to avoid a distal lumbar fusion. In one line, hybrid is selective thoracic fusion extended into double curves, where the lumbar component is too big to leave the reciprocal correction and too valuable to fuse. Briefly, technique. Fusion levels by standard selective thoracic fusion principles. LIV is the first vertebra touched by the CSVL, and at an equivocal T12-L1 junction, I take L1, so I'm not extending the tether construct proximally for nothing. The tether then runs from that level to the lower end vertebra of the lumbar curve, usually L4, double row in about 80% of my patients. Fusion first, reposition, then the tether under the same anesthesia. But I stage about a week apart when the curve is over 80 or too rigid. On those, the key point, I deliberately maximize thoracic correction because every degree it takes off the lumbar curve is a degree the tether does not have to hold. Thoracoscopic at L1 and above, retroperitoneal below L2. And a hybrid case. 12-year-old lanky 1C Sanders 4 Risser 2 saw limited growth left and a 90-degree main thoracic curve. No amount of tethering was going to modulate that. So fusion T4 to T11, lumbar tether T11 to L4. At 2 years, the thoracic curve is 8 degrees and the lumbar curve is 5 degrees. Kyphosis is restored from 21 to 29 and every lumbar segment below T11 is still moving. This is the patient the hybrid exists for. Our hybrid series. We had 23 consecutive patients with a minimum 2 years and with a mean follow-up of 46 months, almost 4 years, with a mean age 13 and a half, and upper thoracic 37 to 10, main thoracic 62 to 10, almost 84% correction, and the thoracolumbar curve 50 to 12 degrees with a correction. And notice the lumbar curve keeps improving after first erect rather than drifting back. And coronal balance improves from 15 to 9 millimeters. The number I care about most in this table, not one patient finished with a lumbar curve over 30 degrees. And this is how that correction is actually produced in our 23 patients. Standing probe, 50 degrees. After the thoracic fusion alone, on the prone film, on the table, 20, which is almost 55% spontaneous lumbar correction, before I have touched the lumbar spine. Reposition to lateral decubitus, and it drops to 6 degrees, purely positional. The tether then takes it to -4. Upright, it settles at 13, and at final follow-up, 12. So the tether actually is not producing the lumbar correction. It's controlling the residual deformity and holding it fusionless. That is a far smaller mechanical job, and I think that is why this construct behaves better than a standalone lumbar tether. And the honest part, breakage in 39%, 9 of 23, right in line with the literature. But it caused nothing measurable. Final lumbar corp, loss of correction, coronal balance and SS22, all the same with or without the broken cord, and nobody needed revision for it. The one caveat is a lower final FVC in the breakage group, but small numbers, so we should interpret carefully. And the useful finding, preoperative flexibility did not predict breakage, and neither did spontaneous lumbar correction. What predicted it was the residual lumbar curve, lumbar cup on the table immediately before I tensioned, 10 degrees versus 5. What the court is asked to do at that moment is what determines whether it survives. So to close, tether the lumbar spine because that is where motion preservation is worth the risk. For an isolated lumbar tether, lanky 5, 40 to 60 degrees, bending below 30, Risser 0 to 3, these are the good candidates. And while the triradiate is still open, we should better brace rather than tethering and try to buy time. Go hybrid when the thoracic curve is too big, too stiff, or too mature to modulate, and when the fusion would otherwise reach L4, and correct the thoracic curve fully, the tether should be finishing the job, not doing it. Thank you.
Excellent. It did a very, very eloquent job there. There are a couple of Q&A questions. Baron, maybe I'll ask you this because you've got tremendous experience as well in the hybrid space and lumbar tethers. A great question about the sagittal plane.
Yeah.
What parameters are you looking sagittally when you're considering maybe VBT versus fusion or hybrid constructs?
Very important. I think we looked at kyphosis maintenance a couple of years back, comparing posterior fusion versus tether. And in the hypokyphotic spine, most of these patients are hypokyphotic. There's an improvement for both VBT and fusion, but it appears to be better. And so if somebody's frankly lordotic or just very straight, they're a negative modifier, I would tend to favor thoracic fusion for those patients. So that's one reason, and Ahmet has described that in his talk, for doing a thoracic fusion, the lordotic or very hypokyphotic spine. One of the other things is that I look at the sagittal stable vertebra to avoid junctional kyphosis. I will tend to fuse a little more distal to get to the sagittal stable vertebra so as to avoid distal junctional kyphosis. And I don't hesitate to go into the lumbar curve a bit. As Ahmet said, let the tether finish the job, not do the job. So I'll tackle even larger lumbar curves than what he's presenting, but I will go into the lumbar spine with my fusion toward the apex, and that'll help unwind the lumbar curve and take some of the tension off the tether when we correct. So I think those are some of the parameters I take into consideration.
Excellent. Dan, Noelle, any other items for the sagittal plane correction where you might do a fusion as opposed to doing the VBT, particularly for thoracic spine? How hypokyphotic will you go?
Yeah, I think you have to pay particular attention to that, Firoz. I've had a number of kiddos that wanted to be VBT candidates, but because of their sagittal, almost lordosis sometimes in a way, it precludes them, and they're probably a better thoracic fusion candidate. So,
excellent. Anything to add, Noelle, or I can close it up?
Yeah, no, nothing at this time. And thank you for the plug for PoseNet and the Squid, both for a fusion and a VBT module. So let's just keep learning from each other, and we'll make both of these procedures, both fusion and tether, more reliable and safer for our patients.
Great. Well, I really want to thank the outstanding faculty and their talks. I always learn lots from them, and I hope all the participants did as well. We do have one last webinar, again, brought on by the Setting Scoliosis Straight Foundation, which will be at the end of October. So after the SRS meeting in Australia, it's going to be on Sherman's kyphosis. The date and time is there on October 29th, again, 5 p.m. Pacific Standard Time and 8 Eastern Standard Time. So please feel free to join us. We also have a YouTube channel, and if you subscribe to the channel, you can get educational videos, recorded webinars from the past, as well as some publication videos from the harm study group. So I would ask the surgeons on the call or on this webinar to certainly consider signing up for our YouTube channel. And then we've got our surgeon performance program. So again, this is in partnered with POSNA for the Surgeon Quality Improvement Database, which is SQUID. And as Noelle just mentioned earlier, it's both for fusion, but also for VBT. So surgeons that are getting into this space, you have the opportunity of this program, and there's a QR code for the quality initiative. And next slide, Harvey. And finally, as Dr. Samdani said earlier, the Setting Scoliosis Straight is a non-for-profit organization. And if you found benefit in the talks or the previous webinars, we do ask that you consider a donation in kind. This is, of course, our QR code, so feel free to do that. And we very much appreciate any support that we can have for our organization. Again, I want to thank all the attendees, but of course, this outstanding faculty. Right after the webinar ends here momentarily, you will get a pop-up survey questionnaire. Please feel free, and we request that you fill this out so that allows us to understand, future webinar planning, and of course take feedback on how we can improve this and do this. So again, with that, I want to wish all of you a wonderful rest of your evening and a great weekend, and hopefully you'll all have a great summer ahead.